I'd like to thank Professor Boots for his comprehensive presentation and take a few moments, next slide, to introduce, next slide please, the members of the panel. So Professor Boots is Chair for Otorhinolaryngology and Director of that department at the University of Bonn. Next to him is Professor Rapides, who's a Professor of Surgery at the Greek Anti-Cancer Institute and has a background in oral and maxillofacial surgery. Professor Volker Seifert, who's Professor and Chairman of the Department of Neurosurgery here in Frankfurt, and recently moved to Frankfurt, Professor Klaus Rodel, who's Director of the Department of Radiotherapy and Oncology here. Next slide. So I'm going to focus most of this group discussion on cases because we've heard already that this is sort of a heterogeneous group of tumor histologies arising at a heterogeneous group of tumor sites, so the level 1 evidence and even other low numbers of evidence are few and far between, and I think discussing some cases will bring out some points. So I have prepared some cases, and as we present these cases, I'd like the panelists and also the audience to keep in mind the following points for discussion. One is the role of non-surgical therapy. Does induction chemotherapy play a role, radiotherapy alone, or combination of chemo and radiotherapy? Next slide. And then the role of surgery for primary therapy, for salvage, and also, thank you, we've heard already there can be open and endoscopic approaches and what would be preferable in each situation. I also invite particularly medical oncologists in the audience to participate because while we're multidisciplinary, we're primarily from different disciplines of surgery with the exception of Professor Rodel. I think maybe systemic therapy has a role to play in the management of some of these cases. So this is a 48-year-old gentleman who presented with nasal obstruction from this tumor in the right side of his nose, and this was biopsied at an outside institution, was confirmed as squamous cell carcinoma. So Professor Rapides, tell me a little bit about how you would approach this patient and further workup and treatment.
Well, it's, as we all expect, is a case which has an extensive squamous cell carcinoma going through the upper part of the middle third of the face and going backwards towards the anterior cranial base and perhaps invading the dura as well. Well, the surgical approach would have been surgery, and then, as we will not have clear margins, surgery will be complemented with radiotherapy. The role of chemotherapy in the tumors of the middle third of the face has lately been instituted. We have had some excellent results with induction chemotherapy and then followed by radiochemotherapy with having in mind to downstage the tumor rather than cure the tumor. And to some of our amazement, lots of these patients, when they responded completely with induction chemotherapy, they continued to improve with chemoradiation therapy. And then when you would perform some biopsies 6 months after the completion of the treatment, you would find no viable tumor. But the difficult thing is to choose who is the patient who is going to respond into a non-surgical treatment. And what about the patient that with this kind of extent of disease will have a progressive disease during induction chemotherapy? So again, it's the tumor board's decision. I would have approached this patient with a TPF, giving him 2 courses of 21 5 days infusion with 5-FU and a taxane, and then if there was visible improvement, I would continue with chemoradiation therapy. But if after the induction chemotherapy there was no sign of clinical improvement, I would go with an operation.
It sounds like a very sound approach. Here in Frankfurt, Professors Rodel and Seifert, would you approach this patient similarly, or would you offer surgery up front?
Well, if you read the textbooks, then you would come to a conclusion that radiotherapy has not a very established role in this kind of disease, at least not in the preoperative setting. It is clear that post-op radiotherapy after surgery is a standard of treatment in these cases. But preoperative radio or radiochemotherapy that has been established in a lot of other tumor sites has no clear established role in this sinonasal cancers. But yes, I would go for pre-op treatment, either neoadjuvant chemotherapy, and then go to surgery and give post-op radio or radiochemotherapy for close margins for these tumors, or even go for preoperative radiochemotherapy in order to improve downsizing of the tumor.
Very good.
I think for me as neurosurgeon, it's relatively straightforward. I mean, the ENT colleague and the colleague from radiation oncology, they are the leader of the therapy. And from the lateral MRI, I'm not sure if the dura is really infiltrated. I don't think so from the MRI that I have seen. So I think it's, if surgery is necessary, and I think definitely that surgery has to be done, it's of course done by the ENT colleague, and we would be happy to join. And to add our expertise, I don't see a way to treat these patients via a transcranial approach, but we would be happy to join in. And just to have a look if the dura is infiltrated, if you are coming from below via your ENT approaches, and then just to assist. But definitely the colleagues from ENT are the leaders of the therapy in this case.
Would your colleagues here be inclined to do an open approach or endoscopic approach for this particular tumor, one or the other?
There is no, in this case, there is no reason to do an open endocranial approach, because obviously the dura is not infiltrated. And if you would like to use an ENT approach, endoscopic approach, of course, this is something that you as ENT colleagues have to decide. We can add and we can offer our helps in whatever approach you want to use.
Okay. Thank you. Professor Boots.
Well, the problem in this case will be the infiltration into the orbit. If you do an endoscopic approach, you hardly can reach this area. Well, you can reach it when you remove the tumor piece by piece, but still there's some risk. So it has to be stressed that in this case, probably an open approach could be better. I would not do an endoscopic approach because it's extending far too lateral. I would then just, instead of an open approach, do midfacial gloving. I think that would be certainly an approach with less mortality, morbidity than an open approach, and with also an excess which allows you to remove the whole tumor. But I'm not sure whether you can remove the whole tumor, whether it doesn't infiltrate the cavernous sinus. And that's a main problem in these cases. That there, in this area, we have to leave tumor. And from that point of view, it's necessary to have post-operative radiotherapy or chemotherapy.
Professor Shaw, you had a comment?
Hello. Thank you, Jeff. It's interesting, Professor Rapidis made a comment about induction chemotherapy. We know we are into skull-base surgery nearly 40 years for anterior craniofacial resection, and we haven't made much progress in terms of local control. That has remained steady over 40 years. The North American Skull-Base Society currently has an open protocol of induction chemotherapy followed by surgery. Induction chemotherapy is platinum-based treatment, 2 cycles. The first 50 patients all will have resection of the tumor in the conventional fashion, anterior craniofacial resection, to see what proportion of patients have a CR and how many of them have a negative specimen. If indeed that first phase of the study shows a significant number of patients who have a clinical and radiological CR and whose surgical specimen are negative, the next phase would be to randomize those who get a CR to have only radiation versus surgery followed by radiation. I think it's an exciting protocol. The accrual is rather slow. It's hard for surgeons to give up surgery and have their patients treated by something else before the operation. But I think it will come about. The PI on the study may be in the room, Dr. Sandeep Samant, who is on the faculty, and he is the PI on the study. And we hope that over the course of the next 2-3 years, we'll have more information as to the defined role of induction chemotherapy for such tumors. Jeff, if you will permit me, I want to make one more comment, and that's in relation to the data presented by Professor Butz. Local failure has been the most important reason of treatment failure in anterior skull-based malignancies. Almost 8-9 years ago, we did an international collaborative study of over 1,500 patients from 17 centers. So it was a cross-sectional study of various centers across the world, several from Europe. And the numbers remain steady, as I mentioned a moment ago. 40% of the patients have positive margins regardless of the most generous operation in the best of the hands. Local failure was the first cause of treatment failure. And survivorship depended on histology. There were the best group, esthesioneuroblastoma and low-grade sarcomas, over 70 to 80% 5-year disease-free survivorship. There was the worst group, melanoma, high-grade sarcomas, and poorly differentiated carcinomas. And all others fell in the middle, which would be adenocarcinoma, intermediate-grade mucoepidermal carcinoma, squamous carcinoma, giving you a 59% 5-year disease-free survivorship. So the good responders are well defined by histology. What we need to move forward is to how can we build upon these histological features and select out patients who may be candidates for endoscopic surgery under selected local circumstances, or those who should not be operated upon because we don't do well with them.
Well, those are very excellent comments, and I look forward to hearing the results of that study. I think as Dr. Rapides presented this approach, it had a lot of appeal, but it'll be nice to have evidence from a large multi-center trial to support that. Are there any medical oncologists who want to comment on this case or the use of induction chemotherapy before we move on? Barbara?
I don't know if people can hear me. I think we obviously have kind of a dearth of evidence about the use of induction chemotherapy in this situation. But the activity of induction chemotherapy has become pretty clear in terms of the high response rate and the feasibility and the fact that these patients are not rendered unsuitable for surgery by getting the induction therapy. And I think in our hands, it tends to come up most often when the patient is initially reluctant to go through with the surgery based on the way it's described, and sometimes after a good response, they, change their minds.
Great, thank you. Could I have the slides again, please? So this particular patient ended up actually presented to me with recurrent disease, and he was treated with upfront chemoradiotherapy without an induction phase, and he persisted through that treatment, and he really didn't have any other option but surgery, and actually wanted surgery initially, and he had this had significant orbital involvement on some of the other cuts, and he had to have an orbital exoneration with anterior craniofacial resection and free flap, and he's done well. Next slide, please. Or I have it, sorry. So this is another patient that presented fairly recently. She's 74 years old, and after taking a biopsy of this, all the appropriate immunostaining was done, and the diagnosis of sinonasal undifferentiated carcinoma was made. So, Professor Rodel, how do you tend to treat those here?
Yeah, this is typically a case where you need multimodality treatment. Surgery alone for this patient would definitely be not the appropriate case. And we have now some, of course, no randomized trials, but we have now accumulating data on radio